Sir, you can start the session. The room is
Okay,
open for attendance.
okay, thank you, Esmada. We'll start. So, good evening to all of you. As usual, I think 2-3 short cases first before going to the long case. Just 1 minute. Can you see my slide?
Yes, sir.
Okay, we'll start with the first one. Okay, these are all 2-3 short cases which comes to the OPD often and on. This is a story of a 50-year-old, 55-year-old, 54-year-old woman. She presented with the history of episodic facial deviation to the right side associated with closure of the right eye for the last 2 weeks. The episode used to last for 2 to 3 minutes and recurs again on the same day, or many times in the same day. No other complaints. It is a short history of episodic facial deviation to the right side with closure of the same side, closure of the eye on the same side for the last 2 weeks. This is the video of the patient. Look at the video. What do you think about this condition?
ഒന്നും ചെയ്യരുത്. ഇനി മുകളിലോട്ട് നോക്കമ്മ, താഴെ നോക്ക്. തല വരിക്കരുത്, കണ്ണ് മാത്രം. ഇടത്തോട്ട് നോക്ക്, വലത്തോട്ട് നോക്ക്. നോക്ക്, ഇടത്തോട്ട് നോക്കാൻ. അത് തന്നെ. ഇനി വലത്തോട്ട് നോക്ക്, ഇനി മുകളിലോട്ട് നോക്ക്.
Ocular movements were all normal.
മുറുക്ക് മുറുക്ക് മുറുക്ക്
Closure eye is normal.
മതി. ഈന്ന് കാണിച്ച് നല്ല പോലെ കാണിക്ക്. ഇനി വാ തുറന്നേ, ആന്ന് പറ.
Parietal movement normal, tongue movement normal.
ഇങ്ങനെ എന്നെ നോക്ക്.
Sensations are all normal. Hearing normal. Rest of the claimants are normal. And there is no motor system abnormality, no incoordination. So apart from the spasms noticed, rest of the examination was with the normal limits. So what do you think the patient is having? What is your impression?
Functional, because dissectable is there. Psychogenic. Functional.
Okay,
First will be functional, but still we will have to keep in mind that is there any paroxysmal episodic disorder?
Okay.
That should be organic, something is to be, but first will be psychogenic.
Correct. You're all correct. But one thing we should keep in mind, sometimes hemifacial spasm need not can remain for a long period of time. That you also have to keep in mind. But here, what is against the hemifacial spasm?
Distractibility, sir, and the deviation of the lower face.
Pardon?
There is distractibility is there and
Right, exactly. So if you look very carefully, the jaw is also deviated to that side, not only the face. Second thing, when I distracted it, it became totally, it decreased to this gait extent. So what is all said correct, this is functional. See, the second part of the video is more obvious. I distracting with asking to repeat eye movement, hand movement.
ശരി, ഇനി ഒന്നര എൻ്റെ വിരലിൽ തൊട്ടേ മുഖത്തോട്ടെ മറ്റേക്കേണ്ടി ചെയ്തേ.
Then it becomes the facial deviation improves.
ഇങ്ങനെ കാണിച്ചേ പെട്ടെന്ന് പോലെ. ഫാസ്റ്റായിട്ട് വരട്ടെ.
That means dissipates with distraction. And so what is the pardon? Yeah, so it's a straightforward case only. So the thing is that I put the patient on anxiolytic for 2 weeks and asked to come for follow-up. Okay, then came for follow-up. And this is after 2 weeks.
ഇങ്ങനെ നോക്കിക്കൊണ്ടിരിക്കേ.
See, this is our not demonstrating now a different kind of movements.
ഇങ്ങനെയാണ് വരുന്നത്. കുഴപ്പമില്ല.
And patient falls unconscious. So now the diagnosis is very simple. Okay, now just to bring to notice that some kind of funny facial movements are all kind of as a functional disorder. This is from literature, the so-called functional facial movements. These are all these kind of a functional movement disorders which are described in literature. So that's only a short case. So shall I go to the next case?
Yes, sir.
Okay. Now, these 2-3 cases are from Dr. Samia from Calcutta. There are all short cases only. One is a little longer, but okay. It is a story of a 7-year-old boy from rural Bengal. So he suffered typhoid fever with prolonged diarrhea, and the fever lasted for over 1 month. He was managed with IV antibiotics and fluids in a subdivisional hospital. He presented now with history of frequent bumping into the objects and searching movements while playing, following discharge from the previous hospital. He was also found to have inappropriate smiling and over-familiarity, decreased speech output with slurred speech. These symptoms were static for the last 1 month since the episode of fever. So, story is a 7-year-old boy had typhoid fever with diarrhea and fever, lasting for 1 month, then managed with treatment, managed with antibiotics in the hospital. On recovery from the episode, he was noticed to have frequent bumping into the objects, searching movements while playing, following discharge from the hospital. In addition to his visual problem, he was also found to have inappropriate smiling and over-familiarity, decreased speech output with slurred speech. These speech symptoms were static since last 1 month. So this is the video sent by Dr. Sami. I will share it with you.
নিচে তাকা
Let's put in
ডান দিকে তাকা
the movement.
বাঁদিকে তাকা ধর 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 ধর
First, touch the phone.
গুড ছেড়ে দে আঙুলটা ধর আঙুলটা ধর ধর আঙুল গুড
Pupils were normal, reacting to problem.
এই আঙুলটার দিকে তাকা এই আঙুলটার দিকে তাকা 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 ধর 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 ধর
Okay, what are the findings from this video? What is your interpretation? Am I audible? Hello?
Yes, sir. Yes, sir. Audible.
Okay. There is no sound coming from the other side, I thought. You want to see the
Some
video?
blindness is there. Some blindness is there, but auditory flow is preserved.
Okay. Blindness is there apart from anything else? Apart from blindness?
Subjects and pursuits are not.
No, the ocular
not
movement
present.
difficult to test, no, but able to quickly test because he's blind, but still he is normal. Using in a blind person, how to test the ocular movements is that he will not be able to see the object. So take his own hand, without his own hand, ask him to move in all directions with finger, not your hand. Patient's own hand, you would catch hold of the hand and move in all directions so that you can check the ocular movements in a blind person.
He asked him to look at
Yeah.
to look at the sides of the sound, no? For the sound
Yeah, correct. That again you can look at, you give the sound the direction and look at the eye movement is another method. But it will be difficult to direction all 6 directions. With the hand, you can all check all the directions up and down. The sound in all directions will be difficult. Hand will be more localizable than the sound coming from one position. Okay, so he has got blindness. What else is there? He's laughing, no? Spontaneously laughing.
So
So the
some
final,
emotional lability is there.
yeah, correct. Emotional ability is there. Or yes,
And
could be
he can,
jocularity.
yeah, he cannot see any object, movement of the
Correct.
object.
Correct.
But sometimes on sound, sometimes he can make out the right position of the hand.
Well, that he is able to make out. See, when the doctor clapped, he could correctly localize to the hand.
Localized to the hand. So,
Yeah.
so that is that is, he is visual agnosia like, but tactile is all right. Sound,
No,
through sound he is here.
No, it cannot be called visual agnosia. To call agnosia, the perception should be normal. Because normal perception without recognition ability is agnosia. But here he's not perceiving it. Then we can't call it that. You cannot use the term agnosia.
Yes,
Sir,
Yeah,
sir, was the meanings done, sir?
pardon? No, meanings are entirely different.
No,
Agnosia,
but actually, whether the meanings was done or not, I have just asked. Whether meanings reflects.
meanings
Meanings
reflects
reflect.
that.
Yeah.
No. Meanings reflect. I don't know about that thing. This is the video sent by that. But it's quite obvious that he is blind. He cannot be a functional, no? It's kind of obviously blind.
Fundoscopy was done, sir.
Yeah, fundoscopy was normal. Pupil dilation was normal.
peoples were reacting.
They
possibly
can normal.
physical blindness.
Yeah. So where should be the site of lesion for the blindness?
Occipital or optic nerve.
No, optic nerve you can't have. See, invariably the light reflex will be affected. No, there's such a severe loss of vision. If optic nerve is a site of lesion, light reflex will be affected. But light reflex is intact. See, it has lesion in the cortex, cortical blindness.
But occipital cortex.
Yeah, correct. So the site of lesion is occipital cortex bilaterally. Cortical blindness.
And frontal also, sir, because of the smile and emotional ability.
Yeah, there may be in addition a frontal lobe involvement because of the emotional ability or inappropriate jocularity which is trailing. That's correct. So site of lesion is occipital lobe plus frontal, correct? You agree with that?
Yes, sir.
Okay. Now let us see. This is the cortical blindness, inappropriate jocularity, bilateral, indicating that bilateral occipital and frontal lobe affection as already told. Now, what could be the etiology in this site? This all developed following the fever.
Demyelination is one possibility.
Demyelination. Post-infectious demyelination.
Right.
Adam.
Adam, what else?
Infarcts also.
Yeah, some kind of a CVT can occur following fever, venous thrombosis. Multiple infarct in this child occurring following fever. He had a fever on his symptoms. Okay,
Any metabolic cause, sir?
metabolic cause producing cortical blindness. Transient blindness is described. Okay, let us see. So what investigation would like to see in this patient?
MRI brain.
Okay, MRI. Okay, see I'll show the one by one. This is the images from I took from the WhatsApp, so it will be not that clear as you have seen before. This is a CT scan. I'll go one by one slowly. See the CT scan finding. What do you think the CT scan findings show?
Some suggestion of cortical thrombosis, sir. Some prominent hyperdense signal in the cortical.
Yeah, it is asymmetrical in both left hemisphere as well as right hemisphere, both frontal lobes and occipital lobe. It's like something like a cortical, subcortical, like a bed-shaped lesion, likely to be an infarct only. It's likely to be multiple infarct-like things, no? Multiple infarct. So let us see the MRI in this patient. This is the T1 weighted sequence basal cut. This is for upper cut. Significant atrophy of the hemispheres plus subcortical white matter hypointensity in T1, especially in the proximity of parietal region. T2 weight will give more information. See the atrophy of the brain here. It looks like as if the duration cannot be 2 months, maybe more than that, to predict that kind of an atrophy in this child. Okay, then you find this is the T2 weighted sequence. See the atrophy of the both temporal lobes. In addition, you can see the occipital lobe, hyperdensity in the cortex and subcortical region. Temporal lobe, temporal horns are dilated. So much of atrophy is there. And underneath the hyperintensity, there you can also find out hyperintensity in the subcortical white matter there in the subjacent with the cortical subclavian. This is a sagittal cut. Now, this is the flare sequence. That's not going to give much of information. This is the radiant echo. There is no obvious blooming seen in this patient. And contrast is given to give much more information. The whole of the brain, there's multiple areas of punctate enhancement, like focus. See, dot-like enhancement seen in multiple parts of the brain. And much more prominently in the right parieto-occipital region, as well as, both occipital lobe as well as the right or left. This right inferior temporal gyrus. You can see that here. This is the occipital, the occipital sulcus, the visual cortex. That is markedly enhancing. There is a chiral enhancement seen there. This you can see it much more clearly there in the calcarean sulcus. This is upper cut again showing the right parietal is involved here. This area triangular shape hyperdensity. And multiple spot-like, dot-like, some serpentinous like hyperdensity is seen in the medial occipit, medial parasagittal areas in the cingulate cortex. This is sagittal cut. I'll show this picture once again. And this is the contrast one. In addition to that, you see multiple foci of enhancement, like a dot-like enhancement seen in the subcortical region. Some in the basal ganglia, some in the white matter also. In addition to the cortical involvement. So what will be your thinking in this patient with this MRI? Sinus is normal. Sinus is filling normally.
Meningitis, chronic meningitis.
Okay, but you can see the dot-like hyperintensity. Okay, chronic meningitis with multiple vascular occlusion is likely, but this kind of a dot-like thing is it very common like that? This one, dot-like enhancement. Can also make dot-like thing. But one thing is, please go on. Please go on.
So that starry sky pattern in TB, NCC, sir.
Okay, the starry sky pattern NCC is actually due to the calcification seen in CT scan. Okay, this is a contrast MRI. That means that area is enhancing.
Can it be vasculitis, sir?
Yeah, it could be vasculitis. Very good.
Mineralizing angiopathy, something.
Mineralizing angiopathy is it's not a mineral, it's a contrast scan. There's no, in fact, if SWI did not show, gradient did not show any area of calcification or hemorrhage. It is SWI. A very rare case. This is a very rare case.
In a metabolic disease, in fear of atrophy, sir.
Metabolic disease causing vasculopathy, yes.
Could be neurolymphomatosis.
Neurolymphomatosis. That is, neurolymphomatosis affecting in the direction of the nerves only. Thickening of the nerves and enhancement, which is actually the gyrus is enhancing. And with dot-like enhancement in the parenchyma. So this clearly is infarct only, multiple infarct.
ADA, something like
Mitochondrial, sir.
Mitochondrial again, see the taking pattern of an infarct is very uncommon. They can, a mela can produce appearance like that, but they usually show diffusion restriction, that pattern, not in contrast, and the result of this can is not there.
Suicides can present like this.
SUSAC can present with multiple infarct, mainly in the subcortical corpus callosum region, but not in the cortical region like this, subcortical involvement. And they would associated deafness and retinal vasculopathy. Okay, this is a young child. Again, the age is odd. It's all developing following a fever.
ADA, that the new disease is there, no? The metabolic.
Right. That's a genetically mediated vasculopathies. Okay, let us see. So what any other demonstration like to do?
Angio.
Angio, correct. So we'll say the vessel pattern. Let us see the angio. Now you tell me the diagnosis.
Moyamoya.
Yeah, correct.
Moyamoya disease.
Yeah, it is Moyamoya disease. See, the inner carotid is blocked in the terminal portion of the inner carotid artery in the supraclinoid region. And subsequently followed by no major vessel, only small vascular channels can be seen. Neovascularization is seen. And this MCA is filled by the posterior circulation. This is a vertebral artery, basilar artery formed with the vertebral, posterior, and that is feeding the MCA.
There is no smoky appearance.
But that means, see, the smoky appearance occurs at a certain phase of the Moyamoya. As the disease progresses, smoky appearance totally disappears. In the initial phases, smoky appearance will not be there. Then gradually it becomes prominent, and ultimately, as occlusion becomes more, all that vessel also will disappear. The smoke will disappear in the late stage of Moyamoya. See, in fact, even though the fever has been there, maybe the triggering factor, this child had been having this problem earlier. That should be the story which you have to consider in this patient. Bilateral stenosis, supraclinoid segment of ICA with left MCA filled with the posterior circulation. So Moyamoya, secondary. So what are the causes of Moyamoya? Keep in mind. It may be primary or secondary. Maybe sometimes may be genetically mediated. These are the causes: sickle cell disease and trait. Down syndrome is associated with Moyamoya, so also neurofibromatosis type 2. These are genetically mediated disease. There are many acquired conditions TBM can produce because of the vasculopathy associated tuberculous meningitis, arthritis. Head and neck radiation can produce secondary to the vasculopathy. Chronic meningitis described in skull-based tumors. Atherosclerosis of the skull-based arteries, cerebral vasculitis, and sickle cell disease. Sickle cell, I forgot. That's already mentioned. So I wouldn't have done this test. It was already done by Dr. Samia. This is the genetic test done, which shows RNF213. Maybe it may be a bit hazy, and this is a pathogenic variant. I'll tell you about. I have not heard those diseases before. Only he made out this diagnosis and sent to me. So this is called Moyamoya hereditary, another hereditary Moyamoya. So two words about that thing. This is called RNF213 gene-related Moyamoya disease. Again, this is to the article from literature. A few words about this condition. Variants in the ring finger protein, that's called the ring finger protein, that is the full form of RNF. 213 gene are known to be associated with increased predisposition of cerebrovascular diseases development. Genomic studies have identified RNF213 as a major risk factor of Moyamoya in East Asian descendants. However, little is known about RNF213 biological functions, or its associate pathogenic mechanism underlying Moyamoya disease. Could be a key, RNF213 could be a key regulator of the cerebral endothelial integrity, whose disruption could be an early pathological mechanism leading to Moyamoya disease. So I think skip them in the details, all these things are from the literature. So this is one interesting condition. I never knew about it the first time hearing it.
Can we give aspirin?
I don't know. Because since it is not a problem of this thing, what do you call it, problem with platelet problems, I don't know whether it's going to help us in this patient. But whatever it is in stenosis, we give aspirin.
So what is the cause of the punctate contrast enhancements?
Yeah, that's all. That's typically described in Moyamoya syndrome. The IV sign, no, you heard about the IV sign in MRI. If you had a contrast MRI, you can something like a linear enhancing vessels can be seen, subpile enhancement can be seen in the MRI. That's called the IV sign. IV is the plant. So it's something like a plant's branches, it will be seen enhancing like that. So this kind of dot-like thing is the neovascularized vessels which are getting enhanced. They're not in the normal location, abnormal location. So obviously it's not 1 month. It's a chronic stenosis. That is why the neovascularization is occurring. Time for the neovascularization developing.
What was the diffusion like, sir?
Diffusion picture is not given to me. This only picture given to me. Okay. Shall I go to the next case?
Yes, sir.
Yes, sir.
This case also from Salmia. So this child was also noticed as some. Today, after this, I'm going to show you 2-3 higher cortical visual videos showing high cortical visual. Yes. We can find out what is the difference between each of these conditions, how to differentiate one from the other. Some of them I presented earlier. Again, in the context of the present case, that will be useful. Now, this cell again for Sammy, and this history is like that. Nothing is also not a visual problem. We don't know the details is not available. But this video is not for to make a diagnosis, but the phenomenology what it is. It's asked to touch the finger. He's seeing, looking at the finger, but they are not able to direct the hand to the Sometimes his attention gets diverted.
চেষ্টা কর এই আঙ্গুলটা ধরে নে আচ্ছা ওই হাত দিয়ে ধর ডান হাতটা দিয়ে ব্রেনটাও কাজ
So what is this visual abnormality in this patient?
Optic ataxia, sir.
No, it's not optic ataxia. I'll show you optic ataxia later on.
Visual disorientation.
Yeah, this is classical visual disorientation. The why visual disorientation is that he is looking at the object. He is looking at the object, but he is not able to direct his hand to the object. That means that he is seeing the object somewhere else. Even though the object hand is in front, he is looking for the hand somewhere else. That means he cannot exactly localize the position of the object in space. That is called the visual disorientation. In optic ataxia, again, I'm going to show one of the Joyce case I'm going to show subsequently. The patient knows exactly where the object is. Okay. Only thing is that visual input cannot guide his hand towards that seen object. So on reaching the object, it will go haywire. He will remain ataxic. On touching the nose, you'll be touching correctly. I think I'll show the video, then you'll understand how to get dyslexia. So any questions before I go to the next one? Is a typical visual disorientation indicating what? Most likely it can be hemi on one side, but if it's bilateral, it is a bilateral occipital lesion. That is the peristriate cortex. That is visual association cortex involvement. Now let's see
It
that.
happening with cortical blindness, no, sir?
No, cortical blindness is different. Cortical blindness patient is not seeing, and just the first child is a cortical blind child. Because he cannot looking at it, not seeing anything. But this child sees something. But only thing is that cannot direct the hand towards the target. And I'm going to show subsequent videos showing or depicting all these various types of high cortical disorders. Okay, coming back to this child. This is the MRI of the child. This is MRI player sequence. This is the T2. Coronal cut. Okay, I'll go back to the slides once again. Okay, this is the flare. T2. Okay, any thoughts? What it could be?
Posterior abdominal leukodystrophy, sir.
Okay, could be leukodystrophy. But you look at the cortex. Is there anything abnormality in the cortex?
There is no sulci.
There is no sulcation at all. So what is this condition with thickened cortex with no sulcation?
Lissencephaly, sir.
Lissencephaly. So this is some kind of lissencephaly, and with associated white matter hypertension which I described, defective myelination can occur. No, there is no genetic test done in this patient. The patient cannot afford. So most likely some kind of a congenital malformation of the brain causing this kind of a higher cortical occipital dysfunction.
Sir, what is pachygyria?
Pachygyria is also the minor form of lissencephaly, where the gyration is less. Severe form is lissencephaly. Pachygyria, agyria syndrome. See the cortex, there is smooth cortex. See, there is no gyration at all. Okay, so in fact,
sorry, is there any optic atrophy with it?
No, this case I do not know because very difficult to examine. Also, this all cases sent by Dr. Samia to me. And this is only to show the phenomenology. What is the visual cortical abnormality in this child?
Okay, thanks.
These things are only a short case. Now, one may be wondering why a white matter abnormality can occur in lissencephaly. That is well described. I'll skip all those things. The cortex is also slightly thickened with an abnormal increased T2 signal in the underlying white matter, which is not in 25% of the cases. Now, I am going to show some other cases showing higher occipital disorders. One by one, let's sort out the issue. This again, case from Dr. Joy. This is a case, 2-3 cases are from Joy. This is one case. This middle-aged man was brought with a complaint of defective vision for the last 2 days. Okay, tell me what the abnormality is.
എന്റെ പേരിന്റെ തുമ്പത്തോട് നന്ദനൻ
He's asked to touch the finger of the doctor.
ഓക്കെ ഇനി എന്റെ പേരിൽ തുമ്പത്തോടു. എന്റെ പേരിൽ തുമ്പത്തോടു. എവിടെ വയസ്സിനും തൊട്ട് കാണിക്കൂ.
He's asked to touch the wife, touch his wife.
എവിടെ അവിടെ ആരുമില്ല. വയസ്സിനും തൊട്ട് കാണിക്കൂ.
Okay, I'll play the video once again.
എന്റെ പേരിൽ തുമ്പത്തോടു നന്ദനൻ. ഓക്കെ ഇനി എന്റെ പേരിൽ തുമ്പത്തോടു. എന്റെ പേരിൽ തുമ്പത്തോടു. എവിടെ വയസ്സിനും തൊട്ട് കാണിക്കൂ. എവിടെ അവിടെ ആരുമില്ല. വയസ്സിനും തൊട്ട് കാണിക്കൂ.
Optic ataxia.
Okay, optic ataxia. But these are not simple cases like this. So think very carefully. Is it optic ataxia really?
Sticky vision, sir.
Yeah, okay. One, it could be sticky. It's not. What all things you observed? One, he is not directing the hand to the target, right? Just like the first child which you saw, he's taking the not first child, the case before, he directing hand somewhere. Second problem, his eyes are not moving to the target, right? It could be a problem with, as you said, sticky fixation or oculomotor apraxia or a visual disorder. Anything is possible. Okay. Let us analyze the problem. It could be visual disorientation, as told before, or a spasm of fixation or sticky fixation, or an oculomotor apraxia. All are possible. So, which is likely in this patient?
Oculomotor apraxia.
Okay. Imagine you have got an ocular. Now, whenever this is the one usually touch the students. Suppose you have difficulty in sorting out a problem. Think that you have got that disease. And what will be doing that? Then you get the answer. Suppose I get an oculomotor apraxia. I am not unable to move my hands, move the eyes to one position. But still, what will be my ability to believe? I know where the object is. My hand will go that direction. I'm not able to, suppose I'm seeing the hand there. I'm seeing the hand there. I'm not able to look at the hand, but I still can direct the hand to that direction. But he is not directed. His hand is going somewhere else. So it's not a pure problem of, it could be oculomotor apraxia, but it's not a simple oculomotor apraxia, if you take that sense. Same argument.
Oculomotor apraxia with ataxia, optic ataxia.
Okay, that's possible. But again, one problem is that if there is optic ataxia, he will be directing the hand towards the target. Here, actually, if you look very carefully, he is looking straight and he is taking the hand towards that area only, not towards the object. See the video once again, then you'll understand the difference.
എന്റെ പേരിൽ
The eye is
തുമ്പത്തോടു
very
നന്ദനൻ.
looking, not at the object. That could be optic ataxia.
ഓക്കെ ഇനി എന്റെ പേരിൽ തുമ്പത്തോടു.
See now,
എന്റെ പേരിൽ തുമ്പത്തോടു.
he's
എവിടെ
look at the
വയസ്സിനും തൊട്ട്
wife.
കാണിക്കൂ.
See where he is taking his
എവിടെ അവിടെ ആരുമില്ല.
but
വയസ്സിനും
not the
തൊട്ട്
direction
കാണിക്കൂ.
of this thing. See the hand? But if optic ataxia, you would have direct the hand towards that person. So you can say that he is seeing somewhere else and then putting that way. So you can think, you have to think, okay, it's sticky fixation and visual disorientation plus these things are possible. All together is agreed. So this could be due to visual disorientation, possible, but it looks like as he's not attempting to move the eyes. Okay, so that means look at the eye is stuck. So could it be oculomotor apraxia or a spasm fixation? Less likely to be due to oculomotor apraxia since he is not directing the hand towards the target as told before. Now let us see the next video of the same patient. Now he's asked to look to the right and left.
ഇനി വലത്തോട്ട് നോക്കി, ഭാര്യയുടെ അടുത്തേക്ക് നോക്കി. ഇടത്തോട്ട് നോക്കൂ. ഈ ഭാര്യയുടെ ഓപ്പോസിറ്റ് നോക്കാം.
So what does it mean? Is it oculomotor apraxia now?
No, he's
There is
looking.
he is looking. So oculomotor apraxia is asked to look to the right and left, he is able to look them. So oculomotor apraxia is not ruled out. Now two things remain, whether it is a visual disorientation or it can be due to a spasm of fixation. Okay, let us see.
ഇനി വലത്തോട്ട് നോക്കി ഭാര്യയുടെ അടുത്തേക്ക്
No, it shows the normal ocular movement. It shows that disability is not due to oculomotor apraxia or a gaze palsy. Now, we have somebody else say, why can an optic ataxia? Again, unlikely since he was not directing the hand towards the target. The same point I already told you. In oculomotor apraxia or optic ataxia, he knows exactly the position of the object in space. Only thing is that he can direct the hand towards the target. But on reaching the target, it cannot exactly reach the point of the. It is an ataxia. It is a motor phenomena, not a perceptual phenomena. Perception is intact, location is intact, but orientation is intact, but he cannot direct his hand to the target. It's a visual motor disintegration problem, not a visual perceptual problem or a visual disorder of a visual orientation problem. Let's see the same patient. So he is now shown the hand straight in front of the patient. He's touching the pin correctly. So what does it tell you? He has no optic ataxia, no coordination when reaching the target. Second, he's brought the hand exactly to the pen. That means he has no visual disorientation. You got the point. He's still able to locate correctly in the space. Previously, he was not able to locate correctly. Now he's able to locate correctly. So what is the problem now? Lately, tough cases are laid. Then this is a sticky fixation. What he said is correct. Needs to do it correctly. Sticky fixation means I stuck. Why he is able to do like that? Because I brought the target. The pen was brought straight in front of the patient. That's where the eyes are stuck. If you take the object away, his eyes will all be stuck to the previous position only. Because his eyes are stuck to the position where his object is seen. He is unable to disengage from the particular position where he has already looked or target is there. Now look at the first video. Now we'll understand the position, why it is sticky fixation. See, look at the eye. Where he's looking in the eye. Straight ahead, not at the target at all. That is
എന്റെ പേരിന്റെ തുമ്പത്തോടും നന്ദനൻ.
He's again stuck there. See, eyes are stuck.
ഓക്കെ, ഇനി എന്റെ പേരിന്റെ തുമ്പത്തോടും.
Doctor is moving his hand, but eyes are all stuck.
എന്റെ പേരിന്റെ തുമ്പത്തോടും.
He's all taking the hand towards.
എവിടെ വൈഫിനും തൊട്ട് കാണിക്കൂ.
Now his eyes are stuck to the different position now.
എവിടെ അവിടെ
hand is going somewhere.
വൈഫിനും തൊട്ട് കാണിക്കൂ.
Wherever it is stuck, he cannot direct the hand only to that direction.
In sticky fixation, can't they see the peripheral vision? Or they can just see the central vision?
No, the sticky fixation, just like oculomotor apraxia, they can see the peripheral vision.
They're able to see the peripheral vision, they'll be able to touch the object also, no?
Yeah, right. The problem is that if you got a sticky fixation, suppose I said there, I may not exactly know where an object is. Suppose you look straight and show an object in the periphery. It will be difficult to exactly localize. It may come somewhere near. That's the thing they can have. Just like you not focus exactly on the post. Somewhere it will be reaching like that.
Then why is he sticking, like fixating to one this thing, sir?
Yeah, that's one of the higher cortical visual disorder. That's why it's called sticky fixation. They are unable to disengage from a fixated target. Suppose you fix on the target, to look to the other target, you have to disengage from the target. That is the problem in these countries. It's called spasm of fixation.
Just like this frontal persistence and perseverance.
Yeah, I can call that way. Yeah, persistence, correct.
What about sight?
This is bilateral, usually bilateral lesion in the visual association cortices. It is in the upper pathway, the dorsal stream dorsal stream connections. These are all the dorsal stream connections because unable to localize the space in there. These are visual spatial problems.
So if he's told your wife is looking, standing on the left, look there,
Yeah.
and then he'll be able to do.
Yeah. Even with that with the sound he's able
If
to
he's
do.
told, if he's told that he's told that his wife is standing on his left.
Okay.
Will he be able to touch the wife?
Yes, if he did touch the
able to.
wife, but only not by vision.
No, if he is told that
Yeah.
his wife is standing on the left, then he'll be looking onto the left, and then he'll be able to touch.
He can direct. Correct. That by just the information that the patient is on the left side, they'll be able to take the hand to that direction. But if somebody is placed in front, then if the person is seeing somewhere else, he'll direct hand only different area only.
But in the second
Pardon?
in the second video, he is seeing nicely.
Correct. Why? Because the object is brought in the line of fixation only. Suppose in the first part, I'll show the first part of this one. I'll show the first part. I keep it like that. I'll keep it there. Suppose see, look at the eye where he's looking. Okay. Suppose the finger is little down. If the finger is brought up to the line of fixation, he'll be able to touch the hand correctly. You got the way he does not. He knows supposed to the finger.
Oh, okay.
Right. That is what has happened in the second video. The second video, the hand is straight in front of the line. So reaching there correctly, he can locate correctly. Because eyes is focusing on that.
Okay.
Look at the eyes. Look at the eye where he is situated. He's again taking the hand. Line he's looking his eyes are fixated. Okay. Is it clear to you?
Yes, sir.
That's unable to distinguish. That can be confused with oculomotor apraxia. What is correct? Again, oculomotor apraxia also you cannot generate a saccade. But second video shows that he is able to make a saccade. So it's not a problem of an oculomotor apraxia. Ask him to look and left, he is able to look to the right and left. Okay. Then I will show 2-3 other higher cortical problems. This is the
Sir, 1 minute, one doubt. Sir, one doubt.
Yeah.
So we have to ensure that the peripheral field of vision is normal. So,
correct.
so here in this Pareto, so that means the Pareto occipital lesion. So he hit bilateral Pareto occipital. There could be the visual pathway also can be affected. No, sir.
No, the visual field also can be affected. Correct. So that way you cannot lock that. That is your argument. Correct. So what happens if it is that's a problem? What will a normal person do? Suppose I got a field visit. What will you do? I turn the head to the direction. Look at that thing. No, with the field visit.
Yes,
that he's not doing it. His only eyes are only as if it is frozen.
Yes.
Now, associate field visit there nobody can say.
Is there any similar thing like in the ventral stream, like you see only one thing and you are sticking on to that one thing, anything like that? This is in respect to localization of that particular.
That the spatial aspects are all in the dorsal stream. The ventral stream is for the gnosis part, recognition part. There is a color vision, object recognition, on a language, the ability to read. Those things are all come under the ventral stream.
So is there anything that if we give two objects and one, that person will stick on to only one object and not the other object, something like that is there?
Yes, exactly. Suppose I'm showing a finger to you, it's all going with finger. Suddenly I bring a pen from the side, he will not be able to look at the pen. If you take out the finger, again you will be looking straight. The pen is there, he will not be looking. Suppose you got a finger and a pen. You're looking at I'm looking at, are you able to see my finger and all? So, okay, I'm looking at my finger. Okay. Then I bring the pen. Ask you, look at the pen now. I won't be able to look at the pen now. Oh, go on coaxing, you will not look. Okay. Remove the
Okay.
finger. Still, I will be looking. Then touch the finger. Then I will be groping touching the finger, like groping like that.
Okay, sir. Please. Thank you.
Now let's see this one patient. This again, a video given by Dr. Joy.
ഇടത്ത് കൈ കൊണ്ട് ചെയ്യൂ. ഇനി അമ്മയുടെ മൂക്കുമ്പോ തൊടൂ, എന്റെ വിരലുമ്പോ തൊടൂ. ഇനി അതേപോലെ വലത്ത് കൈ കൊണ്ട് ചെയ്യൂ. ഇനി അമ്മയുടെ മൂക്കുമ്പോ തൊടൂ, എന്റെ വിരലുമ്പോ തൊടൂ.
Now, what is abnormality here?
This is optic ataxia.
This is optic ataxia.
Yes, sir.
She is able to touch the nose correctly. But the same target, towards the target, it is ataxia. On the left hand, she did perfectly well. Okay, so it's not a problem of visual disorientation. It's a problem with the right hand, unable to guide the hand correctly to reach the target, or ataxia towards the target. It's a motor phenomenon, not a perceptual phenomenon. Perceptual problem. Okay, this is optic. Now, this is another case of a visual loss. Let us see. This old man was brought with a complaint of defective vision and that he used to bump into the objects while walking. Now, here the doctor is standing on the right side. Left side, this is the patient. Doctor has instructed that the patient to touch his ear. Okay, that is the instruction given to the patient. He's touching his own ear correctly, but where did he search for the ear? I'll show the video once again. So what is the diagnosis? Is it spasm of fixation?
Optic ataxia.
No, it's again not optic ataxia. It's no ataxia at all. Because his hand is not got to the ear. He's searching the cheek, touching the cheek around in and around for the ear. Now his command was touch the ear of the doctor. Because it's again not optic ataxia, spasm fixation, because he's moving the eyes, but only in that area only, in the cheek. The field is not going beyond that cheek. See, look at the patient behavior once again. That is area is searching.
It's visual agnosia.
Not visual agnosia means he is unable to recognize the object. It's not a problem of recognition.
He is not able to touch the ear of the doctor only, but he is able to touch his own ear.
His ear, correct. But it is not hand is not going to the ear, hand is going to the only in the small area in the cheek.
Visual disorientation, sir.
No, visual disorientation is okay, but visual disorientation means he is taking to somewhere else. Okay, but here is where is he searching? Only in that area.
He's searching is right, sir. He's searching in the right position, but he's not in the exact position.
Yeah, not in the not exact. See, the face is there. He knows where the ear is. Okay, but he's searching only in the small area inside in the cheek. He's unable to disengage his eyes from a small area in the cheek and look elsewhere for the ear. That's the kind of thing you observed, no? It's called spotlight attention. That means his attention is riveted to small area in the space. He cannot deviate his attention above.
Why is not simultagnosia?
Correct. This is a type of simultagnosia. What you said is correct. This is that means his attention is related to a small area, not going beyond that thing. Okay. This is spotlight.
Sir, what is the difference from spasm of fixation, sir?
That's also initially told. In a spasm of fixation, what he said is correct. He can look only at that area. But what happens in spasm of fixation? His eyes will not move. Eyes will be stuck to the one target. Here, his eyes are moving. Eyes are searching only in that area. I see the video once again. He's look at you can move, look at the eye and the head of the patient. See, move the head and eyes. He's searching in and around that area. See the head and movement. It's not as if the previous patient, the eyes are stuck like a frozen eyes like that. Did you see the difference between the first patient and the second patient?
Yes,
The
sir.
eyes, yeah, it is stuck like that. That's
Yes,
the
sir.
difference. Yeah. So he's searching, but searching only in the small area. That means his field is only that area. That's suddenly because his visual field has been restricted to a small area.
This ventral type and dorsal type, sir. Simultagnosia. You said dorsal type.
This is a dorsal type. A dorsal type is a problem of the space. All dorsal stream is always related to
Yes,
this
I got it. I got it. Yeah, dorsal stream.
dorsal stream.
Yeah.
The ventral stream is actually simultagnosia is
What?
low visual processing speed. He cannot say to form a meaning of the whole picture. The various elements of the thing has to be kept in your mind. Okay, the visual
Yes,
working.
I
And
got
that has been synthesized. That is problem with the ventral stream. The dorsal stream, the space is affected. In this dorsal stream, what happens? Suppose you write say the word cat, C-A-T, cat, in small letters, small size letters, he'll be able to read cat. But if you write cat in a big letters, large C, large A, and T, he'll only be seeing only A. Okay, because only that A will come under the visual field. You got the point?
That is dorsal.
That's a dorsal. That the usual test which you do, the H and dot.
Yes.
That's a dorsal type of simultagnosia. Now, another patient was also brought with a complaint of loss of vision. This is my own patient. This I presented some time back, but for the I brought it for the because since I got other case with auxiliary function. See, he came with a defective. Look at what is his phenomenon. He said he's not able to see. He said he's not able to see. I told him, tell me when you're able to see. I asked him, are you able to see? He said no. What is his problem?
He's able to see, but he's denying that he can see.
Exactly. Perfectly right. Right. So you think it's a functional problem? It could be. What he said is correct. He said he's not able to see. Any other thoughts?
He is not attentive.
He's attentive.
Visual attention is not there.
Okay. Right. But visual attention is not there. Why is he not? Why is he looking at the object?
He's following the objects.
He's following the object.
But but it is not coming in his visual attention.
Okay, I'll tell you one thing. Let's see the first problem. Can it be, as I told before, he said it's a functional blindness. Suppose he's a cortically blind person. Can be cortically blind. He's not seeing. Okay. I can be
He is
blind.
following, no, sir. How can he be called blind? He is following, no.
Okay, let us see. Now, when it comes to the next question, can cortically blind person follow object?
Yes, sir.
What do you call that thing?
Tectocollicular pathways.
No, that is called the blind sight. I'll explain to that. This is called blind sight. Now, whether it's got a functional patient, this is not the behavior of the functional patient. Functional patient, what will you do if it's an object? He will not look at the object at all. I'm not seeing anything. No, I'm not seeing. Right? Look right and say, no, I'm not seeing anything. He will not follow the object. If you had seen functional blindness, this is what they do. Because he's denying it, no? So he will not follow the object. He is following, that means his eyes are moving there, but he is not perceiving it. If you argue functional blindness, in a functional blindness is possible, but that's not the usual type. So this is well known with the cortical blindness, where the patient can follow a target without perceiving the target. That means that, you see, there is area for perception of the motion, the area V5, is different from the area for perception of the object. From the visual pathway ends in the V1 area, V2, and where we recognize the object, where we locate, when identify the object. Okay? And the motion of the object is detected in the other area, V5. So we move something, eyes may go to the direction, but he may not be able to perceive this. So he said he cannot see anything, but goes on looking in the direction of the movement of the object. So first question, is it a functional problem, or is it a cortical blindness, the blind side? Same thing which I have discussed. Unlikely, because if it is a functional problem, he would deny seeing anything and would not look at the direction of the object at all. What is this problem? This cortical blindness is blind sight. What is blind sight? Some people with cortical blindness can point to a target in space by finger pointing, or even set their eyes correctly on the location of the object in space, which they do not perceive. Some patients have damaged the primary, the same thing. There is no conscious visual perception of that, so conscious perception by vision. However, it has been found that some of these patients may actually be able to detect the same object, some object, as evidenced by correctly pointing into it or fixating the eyes correctly on the location of the object in space. That's called the non-conscious visual processing. What is the pathophysiology? It is believed that, as the doctor was referring to, in addition to the classical retinogeniculate stride pathway, the usual visual pathway, but for vision, there may be other pathways subserving vision, such as the retinotactile, pulmino-extrastriate, and geniculo-extrastriate pathways. Apart from the classical visual pathway, there are other pathways. It is again postulated that the ability to see these patients to guide the eye movement to the target in the blind field may be mediated by the dorsal stream through this extrastriate pathway. You got the point? So it is not going to the B2 area. The fibers from the retina to the tectum, pulvinar, go to the area straight away to the area V5. Okay? So you can perceive the motion. So that can guide, that motion can guide, the perception of the motion can guide the eye movement. Apparently looking like a, onlooker, it looked like a functional problem. That's called the blind sight.
Sir, there is something called redox syndrome, which was described in the British soldiers, their helmet wasn't covering the back of the head completely. So the bullet in a shrapnel injuries resulted in the main occipital V1 dysfunction, and V5 was spared, and they were found to have visual defect, but they could still perceive
Right,
motion.
that is correct. That's called the redox phenomenon. It's also someday even normally also in the disease process. Some people can perceive the motion. Suppose that's why when you ask to touch the visual field, you can easily perceive the motion of the object, but not the object sometimes. Suppose if you visual field, we always give the doctor not to wiggle your finger to touch the visual field, but it's easy for him to detect. So motion perception will be easy rather than the static object. That is redox phenomena. That the motion perception is better than the static perception, perception of the static object. Or perception of the moving object is better than the perception of the static object. That is redox phenomenon.
Is it same, sir? This one?
Same as what you said. Correct. That is because the visual cortex is affected with the motion sensitive areas are spared.
Okay.
Okay, any questions? If any questions, please clarify with me. So that make me also think.
Sir, how can this in cortical blindness only V1, V2 affected and V5 spared?
That depends
Now
on
you're
the area.
telling it is.
That is why this phenomena occurring. In this particular patient you are talking about, same patient.
Yes, sir. Yes, sir.
Yeah, because that area is spared, V5 area is spared. V2, 3 is V1, V2 is affected. So he is cortically blind. But he is cortically blind, but he is able to locate the object by vision. That is, his eyes are moving to the moving object. Yes. Okay. Now let's see. Okay. There is another phenomenon called inverse Andin syndrome. That is easy. This is another same patient. Except that he's actually seeing the object with the normal vision, but denies his vision. It is called inverse Andin syndrome, which is told before. Here the visual input does not reach the awareness center. Here also he will not look in the direction of the movement of the objects. He could neglect the visual heavy space. Now let us see this patient. This is the same patient. Here the visual part is improved. He is able to identify the object. Now let us see the problem now. He is telling he could see the object. I must touch the object. He can see the light. What is it? Same page improved, the visual acuity is improved, vision is improved. You could identify the object, but what is the problem now?
Visual disorientation.
Correct. He identified the object but cannot exactly locate where it is. That is his handy, just like the first patient shown by the Samia's patient. Okay, that is visual disorientation. Now, so this much about the higher cortical function. Any questions in that? So I've shown you cases of cortical blindness, visual disorientation, spasm of fixation, and simultagnosia, that is the restricted field spotlight attention, optic ataxia, all I have shown. Anything? Any other? All disorders, a dorsal stream I have shown. Any questions?
Said that what is this? Like you told that defective motion perception also. The
Right.
What is this defective depth perception?
That is another phenomena which occur again with the dorsal stream. In motion perception service called, I'll tell you each one. In motion perception is what is called echinoptopsia. That is, the patient is not able to see the movement of a thing. Suppose you're filling up a cup with water or milk or whatever it is. He will see initially at one level, then another level, and third time he sees the milk is overflowing. So he cannot see the rising above the water level or milk level in the cup. That is unable to move the object. Suppose if somebody is coming towards you, he will see initially far behind, then little more here, like that. That is the lack of motion perception. In fact, our retina is just like our old film which I make. They're all a series of small static objects. When they run together, we perceive as a vision, as a motion. That is the area of the motion cortex. What is the function of the area V5, which makes the continuous stream, and these symbols are, these frames are run together to make a feeling of the moving. Yeah, that is the problem in the motion. Stereopsis is different. Stereopsis can also occur due to cortical lesion, but there the problem is different. See, to produce depth perception or stereopsis, the visual input on the corresponding area of the retina should fall exactly on the image of the object should be fallen exactly on the corresponding part of the retina. Suppose I'm being an object, I've got two eyes now. I'm seeing an object in front. My cup is in front. I'm seeing the cup. Now, even though if it is falling on the corresponding part of the retina, the image which falls on the retina is not exactly the same. It is different. If you look at an object which goes in one eye, you find that it is little different. Because one part of the object is not seen by the other eye. The other part is not seen by the other eye. So some disparity in the image is there. So the precaution with this image, when it reaches the cortex, the brain is able to fuse this disparity in the image to make a three-dimensional perception. That is stereopsis. The stereopsis is also taking place in the dorsal stream. So this person can have problem with the stereopsis.
Okay,
so the
sir.
three-dimensional perception is lost.
Okay, sir.
Okay, so
Yes.
actually it is a small disparity in the configuration of the image which falls on the corresponding part of the retina, and the brain is able to sense these things, then be able to fuse and make a depth perception. This is area 18, done by the area 18.
And what is this visual extinction? Extinction means extinction.
Extinction is equivalent to that of inattention. That means suppose you could do objects simultaneously. One is able to perceive, one is not able to perceive. If one is only able to, out of the two stimuli, you'll be able to perceive only one. That is extinction. Suppose just like our sensory inattention, you touch either side, you able to touch either side.
Okay, sir. Yes.
But
Same is perceptual rivalry.
Yeah, perceptual rivalry. So
Okay, sir.
that's just like our sensory inattention to the parietal lobe, it is the visual extinction.
Okay,
Should
sir.
simultaneously move, one will not be able to. Individually, you'll be able to perceive. Okay.
Yes, sir.
So I think I'll show one more case from Samia. This is a story of a 10-year-old girl. She had a poor scholastic performance for the last 3 years. Has now presented with complaints of episodic posturing of the right upper limb and left lower limb while walking with infrequent falls, especially while training for the last 6 months. So I'll show once again. Here previously also premorbidly she was got a post-scholastic performance. Now presented with abnormal posturing of the right upper limb and left lower limb. And examination showed it was difficult because of the poor attention. And this is the video of the patient.
আয় আমার দিকে আস্তে আস্তে আয় আবার যা আবার আয় আবার যা 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 পুরো যা পুরো যা আবার আয় আয় আয়, পেছনের দিকে আয় ঠিক আছে যা 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 পুরো যা পুরো যা এবার সামনের দিকে আয় এবার আবার ঘুরে যা আচ্ছা এবার ডান দিকে তাকা বাঁদিকে তাকা ওপরে তাকা নিচে তাকা ওপরে তাকা নিচে তাকা
Downward is more restricted. So in fact, I will show the video once again.
আয় আমার দিকে আস্তে আস্তে আয়
Look at the
আবার
hand,
যা
right and left side.
আবার আয় আবার যা 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 পুরো যা আবার আয় আয় আয়, পেছনের দিকে আয় ঠিক আছে যা 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 পুরো যা এবার সামনের দিকে আয় এবার আবার ঘুরে যা আচ্ছা এবার ডান দিকে তাকা বাঁদিকে তাকা ওপরে তাকা নিচে তাকা ওপরে তাকা নিচে তাকা আয়
So it's got generalized, in fact, dystonia both upper limbs and both the lower limb, but asymmetrical, right upper limb and left lower limb more. And mild restriction of vertical gaze, predominantly down gaze. So what is your diagnosis in this child?
Dystonic lipidosis.
Yeah. So the first possibility one should consider is dystonic lipidosis, that is NPC, Niemann-Pick disease, because of the vertical restriction. Okay, anything else?
Sir, when the patient goes in the backward direction, it's sometimes it is improves.
Yeah, that's classical of dystonia. In
Yeah,
generalized
that is very classical of dystonia.
dystonia. It's a dystonia.
This is generalized dystonia in a young child,
Right.
with some amount of scholastic performance from the very
Correct.
beginning, vertical gaze
Right.
restriction. So type C Niemann-Pick will be first consideration. But we will have to exclude always the Wilson disease in such a situation.
Exactly. Perfectly right. I think Wilson should be considered first because that's a treatable condition. So, okay. Then, of course, there are other things which can produce. These are the various conditions, the dementia and dystonia, NPC, Wilson disease, NBA, PAN2. Kupffer-Ekman disease is another condition where it can produce vertical gaze palsy and Parkinsonism and dystonia. Chorioacanthative cytosis, another one. Then lysosomal storage diseases, mitochondrial disease, organic acidureas. Okay, with vertical gaze palsy, the first thing should be NPC. Wilson disease also can produce vertical gaze palsy, Kupffer-Ekman syndrome. This is from literature only. GNB1 encephalopathy. This is a rare neurodevelopmental syndrome caused by mutation in the GNB1 gene present in dystonia, myoclonus, vertical supranuclear palsy. There are other metabolic diseases which can produce dystonia and vertical gaze palsy include Gaucher's, Tay-Sachs, maple syrup urine disease, mitochondrial cytopathies, and FAST syndrome. And infection like Whipple's disease, HIV encephalitis, and paraneoplastic. This is from the I took from the literature only. So, what investigation you need?
MRI.
Okay, so work up a Wilson first. No KF ring or slit lamp examination. Serum ferritin cerebroplasmin normal. 20 for urine group normal. So you want MRI, right? This is the MRI. This is a T1 weighted. T2 weighted sequence. This is the diffusion. This is a GRE sequence. So what is it? Is it neuroferritinopathy?
GRE is showing blooming, no?
Yeah, what do you find this? This
Pecan.
what? Pecan. This is a typical pecan. See the eye of the tiger appearance.
Pecan.
This is the pecan. The classical pecan.
Eye of the tiger.
Eye of the tiger. But remember, the eye of the tiger is not pathognomonic, as it's a neuroferritinopathy can
Yeah,
also.
even the neuroferritinopathy and Wilson also sometimes.
Yeah. But the problem in neuroferritinopathy, this is not the one. It can produce hyperintensity and hypointensity in multiple areas in the brain, not only in the basal ganglia, but also substantia nigra. Other areas also get affected. And with cystic changes, cavitation. That is classically neuroferritinopathy. And the age is older age group, not in this age group, after 30 to 40 years. So, now, as to the eye of the tiger sign has been reported to occur in other conditions like neuroferritinopathy, MPAN, Wilson disease, MSA, as well as in healthy adults. And I think just for completion, 2-3 slides, I think. These are the classical appearance of PCAN. This is a plan, that is PLA G26 deficiency. So in plants, sometimes hypointensity may not be there in the basal ganglia, but 2-3 classical features described as the claval hypertrophy. Claval hypertrophy is the prominence of the medullary, the spike-like projection here, which you see. There is a claval hypertrophy and cerebellar atrophy. These are the two findings which are typically described in the plan. That is a PLA G26 deficiency, and the vertically oriented corpus callosum. Then in the MPAN, in the BPAN, you find hypointensity in the substantia nigra and the basal ganglia. And the classical one is that this particular sign called that that is hyperintensity in the substantia nigra in BPAN. That one name is that for that particular sign, I forget it. Then there are other things, hypointensity in the subcortical wide matter pavis span. Kuforakab disease again is another kind of another type of NBAA. And this is neuroferritinopathy. Even areas hyperintensity in various sites, not only the basal ganglia, thalamus, cortical ascending nucleus, substantia nigra, as well as with cavitation. Aceruloplasma mimics neuroferritinopathy, but there is no cavitation. But they can associate a subcortical hyperintensity. Okay, so that's the story. So any questions?
Halo sensor.
Pardon?
Halo sensor, Deepan.
Halo sign. It's a halo sign, correct. That's called the halo sign.
There is another halo sign in ultrasound for temporal arteritis.
Right.
Yes, sir.
Halo sign for temporal arteritis. That is an ultrasound. Okay, the main aim of today's class was to show the various higher occipital function abnormality by video, since I got 2 cases shown given to me by Samia with higher functions. I do not know how far I was able to communicate what I had in my mind because my poor English communicating ability. So whatever, I don't know whether I could make you understand what I had in my mind.
It's an excellent thing, sir. Excellent, sir. So we will read, sir. We will read. This is the stimulation.
Okay, right. Okay, shall we close?
Yes, sir.
Yes, sir.
Okay, thank you. Thank you. We'll
Thank
see you
you,
next
sir. Thank you very much.
Thank you, sir.
Thank you,
Good night,
sir.
sir.
Thank you, sir.
Thank you. Bye.
Good night, sir. Good night.
Good night. Good night.